Today we're jumping right into a really specialized high-stakes role within the UK's NHS, the Oncology Clinical Coder. And if you think data coding is just admin, well, think again. Our mission today is really to show you how understanding this one job gives you a shortcut, a view into how public health research, national surveillance, and hospital funding are all tangled together. It's not admin, it's high-stakes intelligence work.
Yeah, it really is. And what's fascinating, the whole foundation rests on this really intricate dual classification mandate. You see, UK oncology data, it can't just use one language. There are two separate, highly detailed coding systems running at the same time.
Two systems. So are we talking like one for the money and one for the actual science?
Pretty much, yeah.
Okay, let's unpack that financial side first. When an acute NHS trust treats a cancer patient, how does the hospital, actually get paid?
Right, so the acute coders, they're the ones focused on the money side. They use ICD-10 for the diagnosis and OPCS-4 for any procedures done. These codes translate the patient's whole stay into data points. And these points are used to calculate something called health-related groupings, or HRGs.
HRGs. Okay, so those sound like the key unit for payment then.
Exactly.
Is the main risk just like getting less money than you should, or can mistakes lead to bigger problems, audits, that sort of thing?
Oh, the stakes are much higher than just simple underpayment. These HRGs, they operate under the National Tariff Payment System, the NTPS. And those groupings directly determine the funding the trust gets. The difference between coding a routine treatment versus a complex cancer pathway, that could swing the reimbursement by thousands per patient.
Wow.
So getting the HRG calculation right isn't just, nice to have. It's crucial for the hospital's financial survival.
Okay, so that's the money side. Let's shift gears. What about the data that isn't tied directly to the ledger? How do we track the actual cancer itself?
That's where the second system comes in. The specialized tool here is ICD-10-CM. That's the International Classification of Diseases for Oncology. This is what the National Cancer Registration and Analysis Service, NCRAS, and the NDRS use for, national epidemiological surveillance. So tracking things like cancer incidence, how common it is, survival rates, that kind of thing.
And how is this ICD-10 different from the ICD-10 used for funding?
Well, unlike the more general ICD-10, ICD-0 is multi-axial. It codes the tumor site, the topography, and the specific cell type, the morphology. But the real key, the critical detail, is the fifth digit. It's the behavior code.
A single digit. So you're saying the difference between a national statistic showing, say, aggressive cancer versus just a benign cyst that hangs on one number.
It absolutely does. That fifth digit, the behavior code, is everything. For example, a malignant tumor gets coded as 3. A benign one is 0. An in situ tumor, one that hasn't spread, is 2. So you see, this divergence means an error doesn't just affect the hospital's funding if the HRG is wrong. It also messes up national data integrity if that morphology, that behavior, is coded incorrectly.
Okay, if the stakes are that high, hitting both the hospital's bank balance and the national health picture, I can see why the job needs superhuman attention to detail. What kind of qualification do you actually need to wield that sort of power within the system?
Right. The definitive step, professionally speaking, is getting the National Clinical Coding Qualification, the NCCQ. Achieving that qualification is really the pathway to the higher specialist pay grade, Band 6. Those are the coders handling the most complex cases, like oncology.
Okay, hold on. We've talked complexity, we talked impact. But what about the reward? Are NHS trusts really paying extra just to get and keep these accredited coders?
Oh, absolutely. The demand definitely impacts the pay packet. Because accredited coders are, frankly, a valuable and quite scarce resource, many trusts offer extra compensation. They use recruitment and retention payments, or RRPs.
RRPs. Now, this is where it gets really interesting for you, the listener. How much are we talking about? What does that premium actually look like?
Well, often these RRPs are set at a pretty standard 15% of the basic salary. So if you look at the current rates for 2024 or 2025, an accredited coder at the very top of Band 6 with that RRP added on, their total compensation can go over £51,700. It's a significant premium placed directly on that highly technical accredited data skill.
So let's bring it all together. The oncology coder isn't just shuffling codes. They're effectively a gatekeeper for hospital finances, critical clinical data, and national public health statistics. All at once. It's incredibly demanding work, clearly, but also highly valued, a real niche.
And if we look ahead, connect this to the bigger picture. The future involves the global rollout of ICD-11. Now, this is a new digital system, and it's actually designed to integrate the kind of granular detail that's currently split out into ICD-0.
ICD-11 sounds like a potential game changer then. Does it integrate both the financial and the scientific coding needs?
The aim is for much better integration, yes. It's designed to capture that clinical detail more effectively within the main system.
So does that mean the skill set changes? If the system integrates the detail, maybe the manual coding part becomes less critical?
Not obsolete, I wouldn't say, but it definitely changes. The value proposition for the coder shifts. It moves away from just manual abstraction, finding the right code, toward more expert validation, auditing the data, maybe more advanced analytical interpretation. The focus becomes less, can you find the code? And more, can you validate this data? Can you interpret what these analytics are telling us?
A really significant strategic shift for anyone in medical data. Something definitely worth thinking about, especially the implications of that digital change on data-heavy careers in medicine you might be considering. Thanks for joining us for this deep dive into data, diagnostics, and the crucial role of the oncology coder.